Okay, switching gears now to talk about the scrotum in ultrasound. And this is a kind of a funny picture that somebody sent me of an actual testicle that seems to have a face on it. Like here's an eye, here's a nose, sort of looking up towards its owner, wondering about why it's in pain, maybe. I don't know. There's a lot of funny captions that people wrote on this website where this ultrasound appeared, but I'll spare you those inappropriate captions. So, anyways, we're going to be talking about the testicles and the scrotum in terms of the anatomy and how to acquire the images and how to interpret them. And just to remind you of the testicular anatomy, you've got the spermatic cord, and its vascular supply is very superior. And then we have, the ductus deferens that comes down, and essentially you've got the epididymis. All the way back here, it's a pretty large structure, the epididymis. You've got the head, the body, and the tail of the epididymis. All this is fair game on ultrasound. And then you've got the testicle itself, which is sort of broken down to where the seminiferous tubules are, and then the outside covering the tunica abuginea. And then the reedy testes is right between the testicle and the epididymis. And all the stuff you can see on ultrasound pretty easily, actually. The best equipment to use when you're doing ultrasound of the testicles is to take advantage of the fact that since the testicles are very superficial structures, you can use the linear transducer. That 7.5 to 12 megahertz linear probe, it's got excellent image quality. You're going to start with the grayscale and then move into the Doppler evaluation. And we're going to talk a little bit about pulse repetition frequency and wall filters. It's good to examine your patient in a frog leg position, and it helps to elevate the scrotum on a stack of towels. And you're going to scan the entire contents of the scrotum, specifically looking at the echogenicity of the testicles, of the epididymis, and the spermatic cord. And the good news is you've got the contralateral side as your control, so you can always compare the two back and forth. I do that quite a bit. Many times I start on the normal side to try to get a beat on the anatomy and then move over to the affected side. And so I'm going to show you a series of testicles here that shows here the probe position, and this is sort of a bad schematic, but this is supposed to be the epididymis here, sort of the head, the body, the tail. The spermatic cord is up here, and this is the probe position. So you start in the sagittal plane here, and the probe does pick up maybe a small portion of the epididymis, the head of the epididymis here. But this whole structure here is the testicle. This is the scrotal skin seen up here. And then we move the transducer maybe a little more superiorly here. Now we're along the long axis of the epididymal, of the head of the epididymis as it comes around here. We can see it just along here, with the spermatic cord seen up here. So spermatic cord, head of the epididymis, and then the superior portion of the in this case the left testicle seen here. Although this diagram does have it on the right side as we're looking at the testicles. Remember, the left testicle hangs a little bit lower. Even though this is labeled as left, the diagram is over the right side. Sorry for that confusion. They look identical on ultrasound, so it probably doesn't matter. Now moving on to the tail of the epididymis, we can see now the tail is down here, and we just basically slide the probe inferiorly, and we can see the tail of the epididymis down here. Again, scrotal skin is up here, and here's the testicle here. And then moving along, the next view is going to be a transverse view. Now we've got a short axis here of the testicle, and we just basically slide the probe along the testicle, and many times we can see a portion of the epididymis as well. And although in this portion here, all I do see is the testicle and the scrotal skin here. And then we just slide that probe down the testicle from the superior portion down towards the inferior portion, and noting the testicle itself for any changes in echogenicity. We want to see a nice isoechoic texture to it, homogeneous. We don't want to see any areas of focal masses or anything like that. And then there's something, actually, it's called the cleavage window, and we can see both testicles this way in the cleavage window. Knowing that the left testicle hangs a little lower, we may need to rotate the probe slightly to have a true cleavage window where we see both, basically the same axis of both testicles at the same time. Again, the right testicle, the left testicles here, and when you can see them both like that, that's what we call the cleavage window. So it's to compare the testicles. It's a nice view to compare the testicles on. And then if we bring the probe to the side of the scrotum, and now we can actually make out the coronal axis of the, basically you see the entire epididymal body here. And if you get it just right by moving the transducer all the way to the edge of the scrotum, you can see the epididymis as well as the testicle. It's the only view you're going to see the epididymis stretch out like that. Otherwise, as we saw on those sagittal views, we either saw the epididymal head or the tail. But this is a way to see the actual body of the epididymis.
So we're going to talk about the actual technique for scanning the acute scrotum in the emergency department.
Now, a lot of feedback I've been getting is that people want to see more videos of actual probe placement and machine adjustment and things like that. So I think this is a good time to introduce that a little bit more heavily. This is, everybody knows him as Warren Weekman. He's known informally amongst his friends as Dub Dub for his initials, WW, or just Dubs, as my son calls him.
So we're going to talk about the actual technique for scanning the acute scrotum in the emergency department. So the key equipment here, you're going to use your high-frequency linear transducer, as pictured here. And as we come around and look at the machine settings, it's a couple important things that are very different between grayscale mode and color power Doppler that we're going to put on for the testicles. So once you find your actual image of choice, you're going to switch over to the Doppler settings. So press color over here, and you're going to choose from regular color over to color power Doppler, or CPD. Now, to make the machine a lot more sensitive to pick up the lower flow state that's within the testicles, you want to make sure the following settings are present. For the PRF scale, or the pulse repetition frequency, you want to make sure that's in the 600 to 800 range, and to adjust that you can press up or down to get the appropriate frequency here. You also want to make sure that the wall filter is set to low. If it's not set to low, you can simply use the soft keys right here to adjust it to low. This key over here is a general setting, whereas if you don't have the ability to change the actual frequency, you can change from low, medium, to high. Again, low being the frequency of choice that you desire, and you can adjust the scale one more time by pressing scale down to 600 or 800. So one of the important parts of doing this scan is actually proper patient positioning. You'll see here the patient is laying supine. They're going to be in the frog-leg position. And unlike other scans, what you want to do is get a roll of towels underneath the testicles to support them up and provide some support. That'll also relieve any discomfort that they may have. You can also use a different towel here to pull the penis back so it's not directly in your field of vision. So the first things you want to do is you want to maintain with the indicator up towards the patient's head. You're going to do a long axis or sagittal view of the testicle by putting the indicator here, okay? And you'll fan through that testicle accordingly. Okay. Next, you want to go in the short axis with the indicator towards the patient's right-hand side, scanning through the entire testicle in its short axis. A special view is called the cleavage view, which puts both testicles together, and you can compare them for different echogenicity, size, and shape. You will notice that the probe is angled a little bit more inferiorly as the left testicle hangs down a little bit lower. You'll then want to try and get a nice coronal view of the testicle with the indicator up towards the patient's head to view the epididymis as a whole.
And we talk about Doppler quite a bit when it comes to the testicles and other organs as well, but particularly here is where I find it to be most useful. And you know, there's the pulse repetition frequency, or PRF, and the lower the PRF, the less amount of pulses that the machine is sending out, which means that it's spending more time listening than sending. And when somebody's listening more, they're more sensitive. You could think about it that way. So the lower the PRF, the less talking, the more listening, and the more sensitive the machine is. And so this is a situation where you really want to lower that pulse repetition frequency down to 600 to 800 range. And then the wall filters, this is another thing that helps too. If you put it on the low wall filter setting, that will also make the machine more sensitive. And then you can also turn up the gain, like you can the grayscale gain. Well, you can turn up the color gain. When you're working with the Doppler settings, the gain changes to color gain. So what used to be grayscale gain is simply color gain on the machine. The button just changes its functionality to color. And the funny thing about torsion is that you got to be very careful here, because somebody can have torsion and then detorsion, meaning that they may have had testicular torsion at one point and then the testicle untwisted itself, and now there's flow there again. In fact, the flow, once it detorses, can sometimes be hyperechoic, or I should say not hyperechoic, but hypervascular. It can, once flow is restored to the testicle, it becomes extravascular, and you may see a lot of flow there. And it may even confuse you. You may think you're looking at an infection like epididymal orchitis, when it's just actually detorsion that followed torsion. So there's a lot of caveats and pitfalls here, and you really have to put all this into the clinical picture, meaning that you're looking at this patient in front of you and you're trying to decide, is this patient more likely to have torsion detorsion, or if this is more likely to have an infection? And a lot of that's based on the way they're presenting, their history, and their physical exam. So with that caveat in mind, there are some basic general principles here with regards to testicular torsion. So first of all, when you look at a testicle and you're trying to decide whether it's got flow or not, you got to look at the asymptomatic testicle first and get a good beat on how the flow is to that testicle. When you slide the probe over to the testicle that you're concerned about, and there's no flow seen to that testicle, well, that certainly adds to your suspicion that this testicle it could be torsed. And so that would make me very concerned. If I saw flow on the other side in the same Doppler settings, I didn't see flow on the symptomatic side, well, that's going to really make me want to find a urologist very quickly to help this testicle out. And then the other thing is, you can see flow around the surface of the testicles. That doesn't rule out torsion. You need to see the flow down in the testicle itself, the blood vessels that penetrate through the testicle. Those are the blood vessels you're looking at, because you can have capsular flow, which is around the outside, the surface of the testicle, but you need to see the centripetal vessels, the ones that run through the testicle. And again, we can have reactive hyperemia of the tunica vaginalis. That's not testicular flow. That's around the capsule. You need to see the penetrating vessels. And sometimes if the testicle isn't torsed enough, you can still see flow there. And so you got to be careful. That's why the presence of flow, again, it doesn't rule it out. It just adds to your clinical picture. So this is an example here of color flow Doppler. The blue is flow in one direction, and then the red is flow in another direction. In this case, the red is arterial, and the blue is venous. Well, how do we know? We put this is a combination of both color flow and pulse wave Doppler. So here's that little TIE fighter. That's the sampling gate. It's over the blue, which has a venous waveform to it down here. And this TIE fighter here is over the red, and it's got a more of a pulsatile pattern. A little bit hard to see on this one. I have another example here that's a little bit easier to see. We moved the probe into a sagittal plane from a transverse to a sagittal plane, and now we can see blue over here, kind of venous waveform, and then over here, red here is a more of an arterial waveform. But this is a normal flow pattern we can see here of just, there's arterial and venous flow seen on this testicle here. This is not a sonocyte machine, this is a different machine called Siemens Accuson. And this is a cleavage window demonstrating both testicles at the same time, the right side and the left side, with the left side of the probe dipped down a little bit. And we can see here both arterial and venous flow to these normal testicles in here. Now, if you do have testicular torsion, what happens is, even without the Doppler, just the grayscale alone, you have an enlargement of the testicle, the epididymis, and the spermatic cord below the point of torsion. Well, why is that? That's because as the testicle's twisting, initially it's the venous structures that get pinched off, and then the testicle can't unload its blood flow, and so it starts to get enlarged. And so even on grayscale, we see enlargement of the gonad. It's the same with ovaries, actually, too. We're going to talk about next session. But with the testicles or the ovaries, either way, when they start to twist like that, it's the veins that get pinched off first. The artery is still flowing, but the vein is pinched off. Sorry about that. And so, because the artery is still flowing, the actual organ, it gets enlarged. And so, when there's, but the echogenicity of the gonad of concern is actually decreased. It's got it looks darker than the other side does. So you can compare the two. This is a patient here who's actually got power flow on right now, and we are assessing this testicle for flow, and there's no flow to this testicle. And in fact, if you looked at the other testicle, this is hypoechoic compared to the other side. We're changing the gain settings a little bit here, but no matter what we're doing here with our settings, we can't get any flow to appear to this testicle as opposed to the other side. And indeed, this patient did have testicular torsion. Again, you want to demonstrate flow to the asymptomatic testes, and then using those same Doppler settings, bring it over. And this is the asymptomatic side. This is the symptomatic side on this patient here. Otherwise, you really can't make a lot of conclusions out about the symptomatic side. Some of the pitfalls here. You align the vascular plane along the long axis. You're going to do the other side as well to get an accurate comparison. You want to keep the angle of incidence at about 90 degrees to the testes. That angle of incidence, we're not talking about Doppler here, we're talking about just the grayscale. That offers the best reflection and reduces shadowing that can occur. So when you have that 90 degrees, that perpendicular plane of the sound going into and then back out of the organ, you get a very nice echogenicity there. Any deviation from that can make it look hypoechoic. And with epididymal orchitis, again, this is an infectious state, okay, itis, infection. And you can have an epididymitis or an orchitis or a combined picture. It's sort of a spectrum. Sometimes it starts with epididymitis and then moves into the testicle, and then you get the orchitis, epididymal orchitis picture like that. And these characteristic findings, again, you get this enlarged grayscale, which sometimes it's difficult to tease it out from torsion or not. You definitely get hyperemia or hypervascular flow to the affected side. With infection, you get increased flow there, and it looks like this. So this is epididymal orchitis. We can see both the epididymis here as well as the orchitis component. This is the head of the epididymis, very enlarged. And then we can see this, the testicle has actually got a lot of flow as well to it. This black area here is a epididymal cyst, very common to see that in the epididymis. This is the spermatic cord up here, epididymitis, orchitis. This is the tail of the epididymis here in a sagittal view. We can see the tail is very hypervascular, as well as this testicle too is hypervascular. Epididymal orchitis. And this patient here just has epididymitis. It's a little bit hard to see. This is the testicle over here. We move the flow box over here, we see kind of a normal flow pattern, but over here we see very hyperemic flow to the epididymis. So this is epididymitis without orchitis here. Again, that's usually how it starts. What are some other pathologies that we can see with the testicle? Well, we can see hydroceles, basically fluid around the testicle. We can see spermatoceles and varicoceles. We can see evidence of trauma, like a testicular fracture. And we can see abscesses as well within the testicle or within the scrotum. This is fluid seen around this testicle here, what we call a hydrocele. And a varicocele is when you've got basically a dilation of the venous plexus here. And it just looks like a bunch of tubes in there with blood in it, so varicocele. It's that, I believe it's called the pampiniform complex, if I'm not mistaken. That's drawing from my years and years ago in medical school in anatomy, but that's where you have the this vascular bed that gets a little dilated, and we can see there's blood flow in there. And then if we look on the other side of the same patient, this is what's known as a spermatocele. It's on the other side of the testicle here. It looks like cystic structures here in the spermatocord, and that's what a spermatocele looks like. So fluid around the testicle, varicocele, dilations in the spermatocord, spermatocele, and then when we see that venous complex dilated with blood in there, that's a varicocele seen there. And then abscesses, we can see an abscess within the testicle itself, this hypoechoic debris that's inside that testicle. So that's a testicular abscess, and this is a scrotal abscess. It's kind of all zoomed in. It's hard to see where it is, but looks like any other abscess anywhere else in the body. This happens to be in the scrotum, or a scrotal abscess. And so when you have a scrotal abscess like that, it needs to be drained. If you get an overwhelming infection there that involves the rest of the perineum, you can be in a lot of trouble, and the patients need to go directly to the OR for something called Fournier's gangrene. And Fournier's gangrene is a type of very aggressive infection in the scrotal perineal area, and patients can die from it very quickly. They need to go immediately to the OR to have it debrided. And when you have loss of homogeneity of the testicle, areas of focality, that is testicular cancer, it affects young men. And this being Movember, this is Men's Health Awareness Month, and a lot of men, including myself, are sporting a mustache to raise awareness, to encourage men to be aware of this, any masses on their testicles, and this is how it can present, just a painless mass in the testicle. And this is what it looks like on ultrasound. You see these focal areas of echogenicity here that is different from the rest of the testicle. And that's obviously very easy to see with ultrasound. And then with trauma, we see this as well. Basically looks like a lot of hematoma in there. This is a patient who had a fractured testicle. He was surfing down in San Onofre, and his surfboard went right up between his legs, got him there in the testicle, and his testicle was fractured. He drove. He was trying to get home to Los Angeles, couldn't take the pain anymore, pulled off the freeway at UCI Medical Center. And I scanned his testicles out there in triage. The one testicle looked normal, but this area over here, lots of blood. And there's a little area there of his testicle that just was normal, but then suddenly abruptly stopped. That's the area of the testicular fracture, actually. Normal testicles down here, and the testicular fracture was seen along here. Lots of hematoma around it. This is another example of a scrotal hematoma. This is a normal-looking testicle here. We're just fanning through it. And then as we get off to the edge of it, we're going to see a lot of hematoma adjacent to this testicle once we move away from it there. And that's what all this other stuff is here. This is all hematoma seen in this patient's scrotum, who had a severe blow to the scrotum, resulting in a lot of hematoma, that isoechoic material. Parts of it are not congealed yet, so it looks more anechoic. Parts of it are echogenic. So to conclude, you want to use a high-frequency linear transducer. You want to look at ultrasound both on grayscale and using color and power Doppler. You want to lower the pulse repetition frequency, turn down that wall filter. That will make the Doppler settings more sensitive. It's important to put the patient in a frog leg position, have them retract their penis back with a towel, and then allow the scrotum to be positioned in a way that you can do both an anterior approach and a lateral approach, getting that coronal view, and using that contralateral testicle as your control. And you want to note the testicles for their size, their echogenicity, how they're aligned, and their flow, keeping in mind that with torsion you want to look at the normal side first to make sure you get a beat on how the flow looks, and then slide the probe over to the abnormal side. And with infection, it's the hyperemia that is the hallmark of infection. And keeping in mind, you can see other things on the scrotum as well with ultrasound very easily: hydroceles, spermatoceles, varicoceles, trauma like fractures and hematomas, and abscesses both in the scrotum and in the testicle. Now, I didn't mention inguinal hernias, but that's another thing you can see. You can see the loop of bowel actually sliding down into the scrotum when they get large enough, as a peristalsing structure down inside the scrotum itself. Okay, thank you. Okay, we're going to talk about ultrasound of the thyroid. And when it comes to thyroid, there's a bunch of different tests that you can do to work it up. a lot of which include blood tests, and I'm sure you're learning all about that in pathology. But with thyroid ultrasound, it can be useful to differentiate a solid structure in the neck that you palpate from a cystic structure, and also to show maybe solid components within a cystic nodule, and to identify if there's more than one nodule or multinodularity of the thyroid. And also you can see if there's associated lymphadenopathy or lymph nodes, which we talked about in an earlier lesson on ultrasound workup of the patient with a fever. So I won't go into that now. But one of the things about ultrasound that is limiting, though, is that you can't really reliably distinguish benign lesions from malignant ones. Now, there's certain factors I'll talk about that make something look more benign, but really you're going to have to definitively say something is not cancer of the thyroid. You really actually have to do a fine needle aspiration and send it off for cytology or biopsy it. You can also do an isotope scan to see how hot the thyroid nodule is or how active it is. And then there's other imaging tests as well that can look at the thyroid. But ultrasound is generally considered a first-line imaging study of the thyroid because it's inexpensive, it's quite accessible, it's non-invasive, and it's pretty accurate in describing the morphology, how the thyroid looks. And when you compare that to when you examine the thyroid by hand, how inaccurate that can be using the physical exam, ultrasound really does have a leg up here. And you can also see thyroid nodules that you never would have picked up with your hand, smaller ones that were unsuspected on the physical exam. And that's why some really advocate ultrasound for being a screening technique for early thyroid cancer. And keeping that in mind, however, there is a similar thyroid cancer rate in non-palpable and in palpable lesions. So just something to think about. While the rate of thyroid cancer is similar in both non-palpable and palpable nodules, whether patients with screening detected thyroid cancer have better cure rates, quality of life, or survival than patients with clinically detected thyroid cancer, meaning through palpation, remains unclear currently due to lack of research. Now, this is what a normal thyroid looks like. We can see this is the trachea right here, and we can see the right thyroid and the isthmus, and then the left thyroid over here. The corresponding netogram is seen down here with the trachea, the esophagus, in this case posterior, though I often find the esophagus a little bit left of midline. And we can make out this thyroid as it goes all the way across here pretty easily, actually, with ultrasound, because it's so superficial. It really lends itself well to using the high frequency linear probe, which gives us really nice images. And here's an example here of somebody who's got just the anatomy here of the sagittal view coming from the side of the body. We can see the netogram with the arterial and venous supply. It's quite a vascular organ. And we can see here this patient's longitudinal or sagittal view of their thyroid stretches out across our screen when we aim that indicator towards the patient's head. Now, there's when you come across a thyroid nodule, there's a grading system for it. And this grading system has been accepted, and this was published by Fukunari in Pharmacotherapy in 2002. Basically, grade 1, when you put color flow on it, there's no color flow inside the nodule. So grade 1 color grading system actually means no flow at all. Grade 2 is when you have flow only out there in the periphery. Grade 3 is where you've got penetrating flow with moderately rich vascularity. And then grade 4, the most amount of flow, what they call high velocity penetrating flow with a very vascularly rich state. Now, this is an example here of a category 2. I didn't show a category 1 just because it would just look like a regular grayscale thyroid. But this is a category 2 flow type pattern here with only mapping, color flow mapping out in the peripheral area. And then we get down here to, this is a transverse ultrasound image here of a mostly cystic thyroid nodule with a mural component that did contain flow. The grayscale image initially shows just predominantly cystic nodules seen here with small solid appearing mural component seen here by these arrowheads. But then with the color flow Doppler here on the same exact patient shows only flow out there in the periphery. So this when we add the color flow Doppler here, it only shows flow within the mural component shown by these arrowheads here, confirming that this is actually tissue up here and not just debris. Sometimes you see a component that's within this nodule and you think, is it debris or is it actual tissue? Well, debris wouldn't light up this way with color, so we know that this is actual tissue here. And ultrasound guided fine needle aspiration was done where they took a needle into this nodule and into this region here, and basically the lesion was benign at cytologic examination. This next one here is a grade 3 penetrating color flow mapping with a moderately rich vasculature seen here. We can make out the carotid arteries bilaterally here. So this is the left thyroid. It looks pretty normal to me. Here's the isthmus. We come across the right thyroid, and it's got this nodule on it, this hypoechoic mass seen over here anterior to the rest of its thyroid. And it shows a moderately rich vascular component consistent with Doppler category 3 type of mapping. And then finally, here's a category 4 high velocity penetrating flow mapping with that's very vascularly rich. And you can see that there's a nodular structure here, maybe even another nodular structure down here, another one, I think I see one up here. And there's a lot of high velocity penetrating flow seen in this particular nodule. This is just a side-by-side image of the same thyroid nodule to demonstrate the role of color Doppler. On the image on the left, you see a grayscale, predominantly solid thyroid nodule. That's what this whole structure is here, the thyroid nodule. The rest of the normal thyroid tissue is down here. And then when we add the color flow, we can see marked internal vascularity. And when you see all this vascularity like this, it really suggests, at least there's a higher likelihood that this nodule is malignant. And this patient indeed turned out to have a papillary carcinoma of their thyroid gland. So when it comes to certain red flags that make us more concerned for cancer, again, you got to do a biopsy to confirm it, but certain red flags, if the patient's male, the extremes of age, if they have a nodule there, if they're less than 20 or greater than 60, if it exudes a rapid growth pattern, if it's greater than 4 centimeters, or it shows signs of local invasion, like the patient has a symptom of hoarseness or they have difficulty swallowing, those kinds of things can make you more concerned about it. So what happens when we biopsy these things? Well, the majority of the time, actually, you get good news back. They're benign, 69% of the time, and you follow them up at 6 to 12 months. And if there's no change, you would probably do nothing. But should there be a morphologic change there, one would consider repeating that biopsy. About 17% of the time, you just don't get enough sufficient tissue back in your fine needle aspiration. And I think that when you do it under ultrasound guidance, that is actually less. You get better results. And so that insufficient value there of 17%, I think that reflects the era prior to doing a lot of ultrasound guided fine needle aspirations. And about 1 in 10 of them appears suspicious on the path report. And these can be follicular neoplasms, of which 85% are benign adenomas. But then it turns out that 5% of the total results here are malignant. And so obviously those are the ones that are going to need to be dealt with. So that's what happens when you do a biopsy. And another thing that comes up a lot with the thyroid is Graves' disease. And you can see that you've got this really hypervascular thyroid nodule here in the setting of Graves' disease. And you can see many times the patient's got the prominent ocular proptosis. We see here a large goiter in the neck. This whole autoimmune situation going on here with these very hypervascular thyroid nodule seen here, very consistent with Graves' disease when we see that type of pattern, just generally enlarged and hypervascular, just revved up thyroid gland. Now sometimes you see these punctate echogenicities within a thyroid gland, and that's basically a little concerning there for a malignancy. In fact, some would even say highly suggestive of malignancy. This is a sagittal view here of the thyroid, and we can see this part here has got this nodule here has multiple fine echogenicities with the arrows showing here. The arrowheads outline the nodule in this thyroid, and fine needle aspiration and surgery both confirm this was a papillary carcinoma. And here's another example here of punctate echogenicities in the thyroid nodule. Here's a transverse view in this case with the arrowheads outlining the thyroid nodule, and this cystic structure within here. Here's this comet tail. In this case, this comet tail, I should say this echogenic structure here had a comet tail artifact with it, and when you see a comet tail artifact associated with a hyperechoic punctate lesion, you're a little bit more reassured. And these comet tails have to do with the colloid crystals within the thyroid nodule, which are benign. And so I'm going to go back one slide and show you the punctate crystals that don't have the comet tails. In other words, these are hyperechoic bright dots here in the thyroid that they don't have a comet tail that comes down, as opposed to, and I realize as I'm saying this it's very subtle, but over here this one does have a comet tail, and so this one turned out to be benign at biopsy. And this is a situation here where we're seeing a sagittal view here of another thyroid mass. This one turned out to be papillary carcinoma. And again, you need to really biopsy these to know for sure. This cystic nodule seen here in this thyroid here went and had a fine needle aspiration. Presumably it was going to be benign, and indeed it turned out to be benign on the path report. And so again, the more cystic these structures are, the more likelihood that these are turn out to be benign. And it says here fine needle aspiration not performed. Actually, there was one performed, and it turned out to be benign, so that was good. Here's another patient here who's basically got a large goiter, and we're doing an ultrasound in our emergency department on this patient's goiter, and we're seeing a very large multinodular structure here that extends out across the screen, and unfortunately they didn't use any color on this particular view, but if they did, you would see a really hypervascular organ consistent with a goiter in the setting of Graves' disease. And here's another one here that's got a very large, complex thyroid mass. Some parts are solid, some parts are cystic, and we can see the vasculature there in the neck, carotid, IJ. The carotid is right next to the thyroid. This is the left neck over here. We can see that's got multiple cystic structures to it. And turned out that we did a fine needle aspiration on this patient, and it came back benign. Just showing you the way that these complex thyroid masses can present. So that's really all I got for the thyroid. It's pretty quick. What we're going to do with the hands-on session is just examine the thyroid in a transverse view and then in the sagittal view, just to get a good idea on the anatomy, what a normal thyroid looks like. Shouldn't take very long.